report on the stimulus package. A draft of the committee's report stimulating enterprise in the economy has been circulated and, as I said, will be considered in private session at 4 p.m. with the view to publication tomorrow. Additional reports are being drafted on testing and contact tracing, Covid-19 in nursing homes, and an interim progress report. We've had extensive discussion of that in the fact that they're being prepared rather than the contents of them themselves in the working group. So we can discuss those, or we can discuss the actual draft report at 4 o'clock.
I agree totally with what you're saying. I understand that UCD may have some research which may help us in relation to the nursing home report if we can perhaps follow that up. I believe it's a very important report being prepared.
Yeah, we'll certainly write to UCD and invite them to make a submission based on that. I believe it'll be very informative. Yeah. Thanks, Deputy O'Dowd. Regarding the work programme, we'll also discuss our work programme at our meeting at 4 p.m. As we're, I think, approaching the end of the lifetime of this committee. I'll bring forward a proposal to meet with Dublin Airport Authority and Shannon Airport Authority, and also the two main airlines which service Ireland, Aer Lingus and Ryanair, before the summer recess. But again, we can discuss that in detail at 4 o'clock. I'm told that we'll be meeting on Friday in the Shannon chamber, as this chamber will be used by the Shannon on that day. Sorry? Musical chairs, yeah, without the music. But okay, without any further ado, I'd like to welcome our witnesses who are in Committee Room 1 from Jigsaw and from witnesses from both Jigsaw and Mental Health Ireland. I wish to advise our witnesses that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. If you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise nor make charges against any persons or entity by name or in such a way as to make him or her identifiable. From Jigsaw, the National Centre for Youth Mental Health, I would like to welcome Dr. Joseph Duffy, CEO, Mr. Paul Longmore, Acting Clinical Director, and Ms. Ryan McGregor, Youth Advisory Panel. And from Mental Health Ireland, I would like to welcome Mr. Martin Rogan, CEO, and Ms. Kate Mitchell, Senior Policy and Research Officer from Mental Health Reform. I won't be calling you to make opening statements as they've been circulated in advance. So I would just like to give the floor then to Deputy Mark Ward from Sinn Féin, who's taking 10 minutes. I take it, Deputy Ward.
Yeah, thank you, Chair. And I'd like to thank the witnesses for today, as well as my first chance to address the COVID committee. Just going through some of the reports that were circulated, and like the World Health Organization has warned that the COVID-19 pandemic risks sparking a global mental health crisis. And it was very telling there this morning to see the Mental Health Reform Survey on the impact of COVID-19 that took place with 75 of your members that was published this morning. 74% of your members agreed that the government has not done enough to address the mental health impact of COVID-19 pandemic. 92% agreed that the mental health services required additional resources to deal with the mental health impact of the COVID-19 pandemic. 48% reported that the COVID-19 pandemic has had a negative impact on their organisation in the month prior to completing the survey, and 55% had to cancel fundraising events or delivery of service, and another 10% are expected to do so in the near future. 76% had to withdraw service they normally provide due to the COVID-19 pandemic. It just goes to show the strain that looks like it's going to be coming down the line for mental health services and mental health provision over the next while. So can I ask how your members will see that they will be able to address these, and what additional resources and supports are needed financially and organisationally? And that's taken in consideration that the World Health Organization recommend that 12% of the health budget should be allocated to mental health, and currently Ireland stands at 7%. Thank you.
Perhaps I could invite our witnesses to.
I'm on now. Thank you for your comments on that, and I think the survey that we published today really does show the increase in prevalence of mental health difficulties, but also the increase in demand on mental health services and supports. And while the sector, I think, has been incredibly responsive and has adapted very quickly to the increased demand and need in terms of mental health, it doesn't negate the fact that there are challenges that exist for these services. As you rightly mentioned, many of our member organisations have stated that Covid-19 pandemic has had a negative impact on their organisation. 75% reported that they had to withdraw services they would normally provide. 35% reported that there's been a negative income on fundraising and earned income over the last month. Over 50% reported increase in demand on their services, and over 80% identified that they expect an increased demand in the future. So I think at this point it is imperative that the community and voluntary sector, in addition to our public mental health services, have additional support and resources at this stage. One of the findings from the survey showed that for 50% of the members who participated, they had not yet received assurances from the relevant departments and agencies that their funding under existing funding agreements and periods were guaranteed. So I think that's a very practical measure that could be taken in the first instance. We're also coming up to Budget 2021, and it's absolutely imperative that there is adequate resourcing for mental health services, not just for public mental health services, but for the community and voluntary sector in Budget 2021, and that there are clear commitments to that. We've seen the publication of Ireland's new mental health policy on 17th of June of this year, and within that policy there's an increased focus on a continuum of mental health services and supports, from early intervention right through and mental health promotion right through to specialist and acute services. And it does identify the need for enhanced community and primary care supports, and through that policy we need to see adequate funding and investment in the services, and a full costing of that new policy this year, and to see funding committed to in the years to come.
I just have a couple of questions for Jigsaw, if that's okay, Chair, as well. And as I say, all politics is local, so this is a kind of a local issue. I represent Dublin Midwest, and I grew up in Knockandalkin, and as Jigsaw know, Knockandalkin was the very first location for Jigsaw, and this was born out of a need for an intervention after a high spate of youth suicides within my area. A lot of these children would have been sons and daughters of friends and neighbours of mine. Jigsaw decided to restructure and move out of the area and go from providing a 5-day comprehensive service within our community to a proposed 1 or 2 day satellite service. And I was part of a really strong campaign that was set up to retain the service in Knockandalkin. And I think that campaign is a testament to the work that Jigsaw had done in Knockandalkin, and that the community really rallied around just trying to keep it there because the vital work that it provided within our area. But with the onset of COVID, there's a lot of residents and a lot of people within the community, especially around the greater Clondalkin area, are kind of a little bit left in the dark on where that is at the moment. So if you can give me an update on what this new service will look like, when it will be operational and where it will be located, that'd be appreciated. Thank you.
Thank you. Thank you, Deputy. And thank you for your question, and thank you also for your support over the last long while for Jigsaw, particularly in Clondalkin and surrounding areas. As you will know, and probably the other deputies will be aware, there's been a significant surge in demand for support and need for support across all of the Jigsaw services. In early March, or the 12th of March, we suspended the face-to-face services, but from today we will be able to roll out those face-to-face services again. Particularly, it's important to say that given the significant increase that there's been in demand, there's been a 200% increase in terms of the looking for support through our e-mental health platforms. We've worked really, really hard over the last number of months to provide both phone, video and then online support. In relation particularly to the support in Dublin South West, what we are doing is providing support in Tala, which will cover all of the southwest area. We had planned to open outreach within the Clondalkin area in April, but because of COVID-19, obviously we had to suspend that face-to-face support. Our plan would be to roll that out and to continue to do that. So as we know from next week, we'll be able to provide face-to-face support within the Dublin Southwest area. What we're able to do at the moment, and what we have been able to do for March, is provide phone, provide video, and provide online support.
Just to come back on that a small bit as well, and one of the problems that we had when it was being moved out of Dublin Midwest to Dublin Southwest would be the lack of public transport and infrastructure. There's a lot of areas that wouldn't have a direct bus up to Tala in the Clondalkin and Lucan area, which is quite difficult. And it's also quite difficult for young people that are suffering from mental health trauma or whatever they're experiencing at the time to actually get on a bus or get on public transport and make their way up somewhere where they had something that was really, really local. So in the consideration of the locality for the satellite service, if you can take that into consideration, that would be really, really appreciated by the people in Clondalkin, that they have an easier access to it than it would be in Tala. Just one more question, and I don't know how I am at time at the moment, but in relation to the face-to-face operation that's due to start on the 20th of July. How do you see that? How do you see that happening? And do you expect an impact on waiting lists and waiting list times as well?
We're following all the HSE and the government guidelines in terms of providing face-to-face support, so following social distancing and so on. So we've conducted an audit of all of our 12 centres across the country and providing the appropriate support within them. We have been offering young people, as I was saying already, phone and video support, and we will continue to offer that combined level of support. For some young people, they do need the direct face-to-face support. They do need to be able to come into the centre and have that as a safe space. So we will be prioritising those young people. And what we will hope to do is that for some young people, they might have their initial assessments within the centre, but then continue the support either through video or through phone. We're hoping to be able to provide, I suppose, a wider breadth of entry points into the service by providing using various different technologies, as I've outlined. We'll have to wait and see, I suppose, in terms of whether there is an increase in terms of referrals, particularly young people looking for face-to-face. What we'll be doing is encouraging them to avail of a number of different options.
Too was through my interaction with the young people in Clondalkin in relation to mental health. There was a stigma, especially when I was growing up around the area, there was a stigma about talking about how you felt, especially for men and young men growing up. There was a really stigma of speaking of how you're feeling. You were worried about what other people thought you and that kind of stuff. And I'd like to just commend Jigsaw, because that was one of the impacts that you had in Oireachtas, was that allowed young people to have a place where they could talk about how they were feeling. But not only that, did they speak in that safe place with yourselves, they were bringing that back out into the community. So they were actually having that peer support with each other, where young people were helping young people in relation to what was going on. So I just want to thank you on that, and I want to thank the witnesses for coming here today.
Thank you, Deputy Ward. The next speaker is from Fine Gael, Deputy Carol McNeill.
Thank you very much, and thank you for all the work that you've been... Is this working? Thank you very much, and thank you for all the work that you've been doing over the past number of months. I know it has been difficult. I just have 5 minutes, so I just want to ask you 2 quick questions. You've talked about different service delivery, different options and different maybe pathways for young people coming in, Dr. Duffy. Are the online options, are they working better for anybody than the face-to-face? Are you getting a different type of interaction? Or what's your experience with that, the nature of this forced change? Can you just talk to us a bit about that in a qualitative way?
I think for some young people, it's an adjustment, particularly if they were attending the service before and they had a relationship with the particular clinician. For some other young people, the idea of providing or getting some support online is a very good introduction, because they can do that anonymously, and then they can build up their confidence in terms of connecting with it. What we're seeing at the moment is there's a roughly 50% split between phone and video. There are certainly some young people who need the one-to-one support, because that's based on their family circumstances or the physical space at home. They mightn't have that safe space in terms of having that call with it.
And just on that particular issue, obviously being locked at home for some people in very difficult situations has been particularly difficult and more exacerbated in certain circumstances. Can you talk to us? Have you had an increased concern about abuse referrals, or referrals that are coming from a background of abuse, or any increase in domestic issues that are impacting on children that is presenting to you? Is that something that you have seen or not seen?
I'll pass that to the Acting Clinical Director, who will talk about some of the data there.
Sure. I think that we are always cognizant of kind of child protection issues and the need to be the need to refer those on to the proper statutory bodies for attention where they present to us as a mental health service. I think that it's been interesting to hear from young people about the experience of lockdown, in that for some young people I think that their family situation has proven very supportive. I think that we have seen the importance of a supportive adult in the life of a young person, and some young people have been, shall we say, pleasantly surprised by how their family have come together to support them at a difficult time when they are missing out on some of the normal structures such as school, friends and maybe sporting activities. I suppose there are certain families who are experiencing extreme distress and stress at this time, and sometimes that is manifesting in more conflict in relationships at home. And certainly, I think, as Joseph was explaining, having different entry points to the mental health system and having low threshold entry points where young people can engage anonymously provides an opportunity for some young people to flag if they are experiencing abuse at home, and to receive the appropriate support or be signposted and directed to the appropriate support.
That's really very interesting what you've said about, the surprise that some children have found at finding perhaps a level of support that they hadn't expected or anticipated. Is that what you're saying? It's been a very different picture for different children, hasn't it?
Absolutely, and I think one of the messages that we always talk about in Jigsaw is the importance of adults, trusted adults in the life of young people. We see that communities, families can play a really, really important role in supporting young people's mental health, and maybe some adolescents might have been a little bit sceptical about that, but when they were trapped at home with their parents, they actually found that sometimes the families really, really bonded, came together, shared time together, proved to be a supportive thing rather than a difficulty. So really a range of experiences without a doubt, and it's very hard to say that there was only one experience for young people during the COVID restrictions.
I'm really glad to have had this chance to talk with you about that, because my own sense has been that this is actually very mixed, because of course when a young person has a relationship with a clinician, to move that online is very difficult, but on the other hand you have all of these different entry points that we're all experiencing in different ways, which could provide greater access. And of course then we've had this different disrupted experience of having more time with families, more time at home, a slower pace, and all of those have different impacts on general well-being and mental health as well. So it is interesting, and while I have enormous time and respect for your sector, other sectors are experiencing similar disruptions to the delivery of their services. So for example, Multiple Sclerosis Ireland, I was talking to them about the difficulty providing physio and other support. So it's happening in every sector, but it is interesting to hear about the complexity and the different experiences of the service users. I'm out of time now, so just thank you very much. Thank you.
Thank you, Deputy. Deputy O'Dowd.
To Look, just the World Health Organization recommends that 12% of total health spend should be allocated to mental health care, and in Ireland, you're saying the number is less than 7%. How do we compare to other countries in Europe, say, in that spend? And the second question I have is about older people who are cocooning or have been cocooning. Many of them on their own have increased isolation, I think increased pressure, and some older people, I understand, may have early stage dementia. And I think there's a lot of concern that while older people have historically been very independent and very settled in their communities, are particularly isolated. So do you have any, how could we improve our services to older people, particularly mental health services in that respect?
Excuse me, if I could take that question, please. Thank you, Deputy, for that question there. I think it's a really important piece in terms of the WHO. And we've received some really good advice from WHO over the last number of weeks in relation to our management of COVID, but they also give advice in terms of the level of resource we should invest in our mental health services. And its minimal recommendation is 12% of the entire health allocation. In Ireland, in the past, we spent up to 23% of our health spending in mental health. When I began my career, it was at that 12%, but it was in the mid-1980s. We have drifted downwards, and unfortunately, we don't compare well with our European colleagues, and we don't even compare well with ourselves in that regard. So I suppose to provide a mental health service in the best of times with 7% of health spending is difficult, and this clearly isn't the best of times, so there's an additional demand coming. And we hear some unhelpful language about a tsunami of need coming. That'll present itself in a variety of different ways in terms of how people have been dislocated and unsettled by the experience, and even individuals who haven't themselves been ill with COVID or had a family member indeed had a bereavement. All of our lives have been changed by this. And it would be very unusual and quite unhealthy if this didn't provoke some degree of anxiety, upset, perhaps anger in some instances, and I think oftentimes family members who have been cocooned together in close proximity. As we've discovered, many families have found an increasing bond in that situation, but some have found that very, very difficult. So COVID has had an amplifying effect. I think from some of our conversations with international colleagues have been really fascinating about this, and some of our US colleagues who have teams who specialise in huge adverse events, for example, weather events or terrorist events. And they describe just the really important need, not just for additional investment, but how you use that. They were describing, for example, after Hurricane Katrina, in the 2 years after that event, the additional spending on just 3 conditions, anxiety, depression, and post-traumatic stress, was $13 billion. That was the same as fixing the levees that had flooded during the Hurricane Katrina event. But it's really important that we remember that we need a whole series of tiered responses. Most communities will rally together, will respond well, and we've actually seen this huge upswing of volunteering, of neighbourliness, and a huge community bond, which for many people have never experienced except in these last couple of months. So that's been a real positive for us. And we've also demonstrated that when Irish people pull together, what we can achieve with good leadership and good support, well informed, and people have used a whole range of different techniques, in particular in the use of technology, to reach out there. I think when you mentioned older persons, and it's really important that sometimes older persons are referred to as people who need care, but our older persons are elders, and they are very wise individuals. They have huge life experience and they want to contribute that. And while they were cocooned away, we were at a loss for that expertise and that wisdom and just that gravity of experience, which is really, really useful at a time of crisis and a time of difficulty. So certainly we know that loneliness is hugely impactful on a person's physical health and their mental health. They say that loneliness is equivalent of smoking 19 to 20 cigarettes per day. If you don't have a connection, if you don't have a relationship, it's really difficult to mobilise and motivate and self-regulate and to share your concerns. And this is why we've been able to use, through our volunteers and our mental health associations right across the country, we've provided over 30 Zoom licences, for example, just to reach out so that older people don't feel so isolated and can make an active contribution, and that's what they wish to do. So I think as mental health services have adapted, and they've shown extraordinary innovation in the last number of months, things that would have been considered science fiction 4 months ago are now routine practice and behaviour. I think that's been a remarkable piece. We need to regain and retain those learnings and advantages, but we also need to make sure that the capacity to serve is replaced.
Just one small point. I agree absolutely with everything you're saying there, but I think there is a cohort, and I can't measure it, obviously. There are older people who've been living alone, who are actually not coming out at all. There is a cohort there. I think we need to reach out because they're afraid for their health and they don't have personal family supports, and I think they are increasingly isolated, and I think that they're increasing issues there. But I welcome everything you said, and perhaps other speakers later on may take up these issues with you. And the final point, could you, if you have proposals that we ought to be doing, in other words, if you could prioritise where we need to spend more money urgently and immediately, I know the list will be endless, but if you could prioritise, where you see the key needs right now, so we can present them in our report if necessary. Thank you, Chairman.
Thank you, Deputy O'Dowd. The next speaker is from Fianna Fáil, Deputy Devlin. You're taking 10 minutes, or thereabouts. Yeah.
Good morning to the witnesses as well. Thank you very much for your attendance here today. Look, for all of us, we've all received calls for people who are in distress, who are in need of the services of mental health. Now, I note that about 90% of the mental health services are actually provided by GP cares or the community primary care teams, and then the remainder would be the community mental health teams. What kind of volume have you seen an increase in since the outbreak, I suppose, of Covid-19 here in Ireland, particularly, say, since mid-March through to today?
I think what we've seen has been that the profile of need has changed in terms of an urgency, and certainly for voluntary agencies like my own and other organisations running helpline and support lines, we've seen the intensity of calls and indeed the duration of calls extending. Oftentimes people are very distressed, and people sometimes find it difficult to step over that threshold to seek help. This is something they haven't done before, and they've often been quite relieved and surprised to realise just the level of support that's there. And agencies would always describe that no problem is too small. If it's a problem for you, if it's impacting with your quality of life and your relationships and your ability to go forward, or your view of the future, definitely reach out for help. And most people gain these supports in the context of their family and in their community and their social relationships. But as you mentioned, about 90% of all mental health issues present to primary care in the first instance, and that's about 35% of all GP activity. And that was abated somewhat in terms of telephone visits, etc., during the early stages of lockdown. And that was a real challenge for people, even gaining access and beginning that conversation. And I think huge progress has been made in the whole area of mental health over the last number of years. So recovery is a very real prospect, and it's important that people step forward and avail of the services and don't feel in any way, like we've seen in other parts of the health system, that people are shying away or staying back for fear of COVID. The pathways have been cleared and are easily navigated, but there are some additional delays because of the requirement for PPE, which poses a particular issue in the mental health context. Obviously, engaging with a person who's in distress or at a vulnerable time while wearing a mask is a very real limitation. And we've been interacting with some of our international colleagues and some world designers on this in terms of ways to get past that, to have a PPE that's appropriate to mental health. So there's definitely been a different nature of need. Many of these can be resolved within local community engagement with volunteers, with NGOs and different organisations who are really happy and pleased to help there, and sometimes using innovative technologies. But also mental health services are available 24/7 for young people, for older people and for the general adult population. That's a really important message for here today.
Okay, thank you. And in terms of the previous question about the 12%, the WHO recommendation of 12% of health service spend be on mental health services, and here in Ireland we're in and around 7%, as I heard you say. Do you have a percentage breakdown of maybe age and gender of those who you've seen, say, in the last 12 months or so, or has there been an increase in any particular cohort? You mentioned young people, for example, and one of the common issues that we all come across, I suppose, is the dual diagnosis, those who may have a drug addiction as well as mental health issues. And what is the view, I suppose, of the overall panel of how we go forward in treating that, and is a barrier to that the lack of funding currently going into mental health services?
I think one of the things we've seen in recent weeks, I suppose, sometimes when a person has a mental health issue, they do their utmost to pretend that they're fine and they minimise and carry on. And I think when family members came together, they suddenly discovered that their partner or son or daughter was actually masking a significant mental health need, be that anxiety, depression, perhaps an eating disorder, drug or alcohol use or gambling, and these have come forward quite pointedly and quite urgently. So I think just in the last week the HSE has published its own report on 2019 in terms of service uptake across all population areas in terms of different age ranges as well. So we can expect to see almost a slow burn effect in terms of the COVID piece. I suppose people cope in terms of the immediacy of the here and now, and having come through that, sometimes people, when they look back, feel the dislocating effect and the fact that certain routines and certain sports that have protected their health in terms of outdoor exercise and a range of different activities and connection with friends, when these are withdrawn, it's only over a period of time that the real apparent effectiveness becomes more to the focus. So we can expect to see this emerging more and more over the course of this year.
May I add to that briefly? Just in terms, and thank you, Deputy Devlin, for your questions. And just in terms of your first comment, I think the most of the data that we have in terms of demand on services is actually in the community and voluntary sector, and we've seen that from numerous groups like my colleagues here in Jigsaw. Spun out the Youth Online Information Service has seen an increase of 44%. My Mind, that provides online and face-to-face mental health services, has seen a tenfold increase. And certainly for particular groups of individuals as well, we're seeing particular challenges in terms of accessing services. So people experiencing eating disorders, for example. So we do need to ensure that those services are adequately resourced and that people have easy access to services. And you made a comment about primary care and that primary care should be meeting 90% of the need, and that is absolutely accurate. But there are issues in terms of lack of capacity there, and primary care services need to be appropriately resourced. We can see that, for example, in the long waiting list for primary care psychology, where we have over 8,000 people waiting for a first appointment. And many of those, about a third, are waiting over a year to be seen for the first time. So while there already is, services are already under strain and we're seeing increased demand, we really need to match that, and the government needs to match that with appropriate resourcing. In terms of particular groups of individuals, I think the UN and the WHO have identified particular groups of individuals that may be at risk, including young people, those experiencing domestic violence, frontline healthcare workers. So our services need to be prepared to meet that need. And I think one of the ways that we can do that is to immediately establish the implementation group as that should be set up to ensure implementation of the new mental health policy, sharing the vision to ensure that the particular needs of these groups of individuals are adequately met.
I'd answer the Deputy's question as well there, just in terms of Jigsaw specifically. Whilst we saw a brief initial dip in the level of referrals around the end of March, since April the level of referral has been rising and rising steadily, and is now at the same level that it would have been last year, and it remains to be seen if it continues increasing. Of note is that there is an increased level of referral amongst young adults. I suppose we are a little unusual in Jigsaw in that we work with 12 to 25-year-olds. So we are seeing an increase in the level of referral from young people around the ages of 18 to 20. And this could be because a lot of those young people may have been affected by the loss of jobs because they would often be working in sectors where that have been particularly affected, maybe the hospitality industry, retail, etc. I suppose one thing that we know about demand is that even pre-COVID-19, the demand for mental health services for young people far exceeded the capacity within the system. So I think we can only anticipate that that will be exacerbated post-COVID-19. But in some ways, I think we already know that we don't have enough capacity within the system. This is something that we knew in January, February and early March of this year, and it remains to be seen to what extent those difficulties and that lack of capacity is exacerbated by COVID-19.
Thank you very much for those responses to everybody for that. And what I would say is, I mean, we spoke about primary healthcare services, and there is a lack. I mean, I would say it's quite patchy, to say the least, in certain parts of the country. And my fear would be for those who live in those areas who can't avail of that, or indeed the pressure and strain on our GPs right across the country, that in itself could prevent and set up barriers, unfortunately, for those who are trying to access services. And that's really an important element for either funding to assist with, or indeed for the review of services. And I thank Ms Mitchell for that, about the sharing the vision. There is certainly a need to see the implementation of that as soon as possible. So thank you very much, Chair.
Costello.
Thanks very much, and thanks very much to all the witnesses. I'd just like to explore the online mental health, the phone, the video, the internet stuff, because we've spoken about some of the benefits of it, and obviously there are lots of benefits to it. But I must say that part of it I'm quite concerned about in relation to people by either way of geography who don't have internet access, you know, or who don't have internet or phones, which I know is certainly an issue with, say, young people in care or young people who had just left care who wouldn't have those kind of tech or, you know, computers or phones to be able to engage in these projects. So could the witnesses talk to us a bit just in relation to some of the pitfalls of working in that kind of remote setting? I'm particularly interested in, you know, we've spoken about some of the cohorts who kind of did better, but cohorts who engaged less, who found it difficult, or cohorts who couldn't engage at all, or who, you know, who you would normally, demographics or cohorts you would normally engage with, but who disappeared during this time of COVID. Like I know one of the witnesses there talked about Zooming with older people. I know my parents took to it, but other people's parents hated Zoom and wouldn't engage with it. So it's not necessarily a service for anyone. So if you could just talk about the pitfalls and the demographics or cohorts who can't engage or couldn't engage in that service, please.
I think what we've seen in recent months has been a rapid adoption of a range of different technologies. And like you say, you know, we've all become very conversant now with Zoom and FaceTime and Skype and Microsoft Teams, etc. And these have been very, very useful tools. And you know, the technology can do certain things that even human services can't easily do in terms of availability, making geography irrelevant, you know, making low threshold access, proactively providing information that people can tailor, dynamic signposting. In our own organisation, we've provided you know, whole conferences for families. We've provided training for older person services and a whole range of different partners right across the community and voluntary sector as well. So there's many things that the technology can do. But we also need to be very mindful that it has its limitations, and some of those are to do with the individual who is just not comfortable with these technologies, doesn't have access, just that digital divide. Sometimes in terms of even trying to reach messages, we found in our organisation, we were buying space in provincial newspapers where we knew broadband coverage wasn't sufficient for people to access our website, where there's a whole range of new materials there. For example, we're actually hosting an international conference in the next 10 days, which was originally due to be in Kilkenny, but we have colleagues from all over Europe, maybe 500 or more, tuning into this. So it confers certain benefits. However, there are very real limitations. Like you say, sometimes in the mental health space, we have individuals who are cautious of service. Sometimes they're reluctant to avail of service. Sometimes family members are very concerned and they're saying, how do I make sure that my son or daughter or my family member is seen? And that simply can't happen when a person's in great distress, perhaps actively unwell, or declining service. And you simply cannot reach out. Often in good quality mental health care, it's about creating a therapeutic alliance, that relationship between a skilled professional and the person availing of the service. And increasingly we're providing more and more peer-led services through co-production. In our organisation, almost half of our staff are people who've recovered from significant mental health needs and are now providing educational programmes and a whole range of different activities through a network of recovery colleges. That human contact and that being present, there's really very little that can substitute for that. But we also know that people sometimes find it more comfortable, they can avail in their own terms and their own time. And sometimes quite deep psychotherapeutics can be offered online. But that is presupposing that the person has a private space in their home, they have the technology, they won't be interrupted, and But we also need to know that if a person for some reason becomes unsafe, unwell, you simply can't reach out and hold that situation and keep it safe. We also recognise the benefits of technology, for example, in relation to inpatient admissions for young people in CAMHS units, in child and adolescent mental health units. Many have not seen their parents since March, and that's been a precautionary measure which has kept them safe, but has been a huge sacrifice to ask of young people as well. So Skype and FaceTime has been a bridge for that, but not quite the same of being in the same room with your child when they're going through a period of distress. So there are very real limitations, and I think we're learning more and more about this technology and some of the clever things it can do, but we just need to know when we can apply that tool most effectively, and equally when it becomes a barrier to people forming that therapeutic relationship, which is key to quality mental health care.
Thank you, Deputy, for the question. I would echo a lot of what Martin said there, and I think part of the key learning for us in Jigsaw and part of what we've been told by young people during COVID-19 restrictions is that there is no one-size-fits-all. There is no one way of providing a mental health service which is going to work for everybody or meet everybody's needs. So I suppose we have worked hard to provide a suite of offerings in order to provide access to as many young people as possible. So working via the phone, working via video call, using online live web chat, using asynchronous communication via email, and also reintroducing our face-to-face services. And really we find that what works best and what's most effective is when we can tailor our clinical therapeutic offering to the unique circumstances and preferences of the young person and their family. That's what's most likely to have good outcomes. So we are trying to have a suite of services, I suppose, that offers choice to young people, that's flexible, that's adaptable, and which can therefore reach as many young people as possible, and the young people who avail of our services are more likely to receive a service which is suitable for them and which is effective for them and which provides them with a good outcome. I think that there can sometimes be a temptation to think that there is a bit of a holy grail, that there's one way, and maybe that's online. And what we've found is that online doesn't suit everybody, in the same way the face-to-face doesn't suit everybody. So a suite of offerings is the best way to offer a quality mental health service to as many young people as possible.
Thank you, Deputy Councillor. You can come in maybe at the end if you have further questions.
No, I'm going.
Yeah. Okay. Thanks. The Deputy Smith for the Labour Party.
Thank you, and thank you to the witnesses for your presentations and answering the questions so far today. Mr. Rogan, you mentioned that in July Mental Health Ireland allocated €90,000 to local mental health associations to replace lost funding. I would imagine that that's not a euro for euro like reimbursement. Is there any indication of approximately how much money has been lost due to the inability to fundraise for your associations over the last couple of months?
So across our network of mental health associations, which are volunteer driven and raise funds in their own local community and spend them within their community, promoting positive mental health and supporting people with significant mental health needs. And right across our network, people have discovered that they've had to cancel different events, sometimes very low-key events. And it's really important because communities really want to support the activities of local mental health volunteers. So we introduced a scheme on the basis that we must say that the public have been very generous, particularly online, and at Mental Health Ireland we're very careful that our own fundraising doesn't impinge on our local volunteer network as well. So we opened up an application scheme and invited groups to come forward, and some found that they were actually doing fine, they could manage, but we also offered that we'll have a second round of funding. But in July we've allocated over €90,000 in a series of grants to make sure that services can continue, so that services can improve in terms of social distancing. I was on a Zoom call yesterday evening with some colleagues working in the Rathmines area, and a very simple device there like creating an awning creates additional outdoor space. So it means that people who could become very, very isolated, perhaps living in bedsits, etc., in inner city Dublin and in the Rathmines area, can still avail of the service, albeit in a measured way, in a socially distanced way. So our approach at Mental Health Ireland is our strategy we call empowerment from ideas to action, and we're saying how can we give pragmatic expression question to public policy, and how can we make sure that people don't in any way feel isolated or in any way left behind. So we've had to reach out to try and bridge that gap to some extent, and this is something we haven't done before, but because of the generosity of people donating online, we're in a position to do that on this occasion. It's really difficult to quantify the actual degree of loss on that, but each association has submitted its accounts, so that's a detail I can return to you with.
Thank you, Mr. Rogan. You mentioned also that a lot of new referrals to your services would, from younger people between 18 and 20 would be due to lost jobs, retail, hospitality sector, and that's very understandable. But has there been any, what levels of, and maybe you can't answer this, of new referrals are for people suffering with anxiety in relation to how the state is responding to the actual pandemic itself? So who have issues in relation to social distancing, physical distancing, people wearing masks, hand hygiene, that kind of thing. Like, are we seeing a big spike in referrals who are people who are directly anxious about these very much front and foremost issues in relation to this pandemic?
I think across our whole population, the people are at a different point in terms of their level of understanding, their comfort with risk, and the adaptation they've had to take on as well. And we've recognised that some people who use mental health services have sometimes found it difficult to adhere to the social distancing limits, and that's been a challenge and quite a concern for family members who've made contact with us. I think going into lockdown is probably a little bit easier. It's a simple message. It was stay at home. Now it's a graded message, and people have to adapt to that and take back more personal responsibility. And sometimes individuals are inclined to surrender decision making, saying, well, an expert told me to do the following, and that's what I'll do. We're now at a point where we're depending much more on the individual and their family context and their local communities and business community to take responsible steps to stay safe and not to allow the virus to return. There's no doubt wearing masks can be uncomfortable for some people, and it can induce a degree of discomfort or anxiety. But I think what's been really, really important in this is just a sense of sonder. And sonder is a sense that we appreciate that other people have complex lives. And what's been really important is that in mental health, this is not a solo pursuit, it's a collective, pooled exercise. And when we care for each other and we signal by wearing a mask in a public space or on public transport, we're actually, it's a courtesy to others and it's reflected back. And that bond has been really, really powerful. It's actually been quite protective and supportive of people's mental health over these last number of weeks. We need to retain that as we go into the next stages. But certainly for people who are concerned about anxiety, there are many, many supports and lots of really good information on websites as well to give you practical solutions to how to overcome any sense of fear they may have. I think Paul has also referenced this as well.
In this.
Yeah, I would just say in terms of the young people that we're meeting in Jigsaw, we continue to see anxiety and low mood as very prominent reasons for referral. And I think an awful lot of young people are experiencing a significant amount of disruption to their routines, to their relationships, their expectations of what their life was going to be like. This year is very different, whether that be in school, in college, whether that be sitting the Leaving Cert. So that sense of uncertainty, that sense of disruption to routine, I think is difficult. And there's also, I suppose, worry and concern for family members who might be ill, who might be elderly. All of these things, I think, are excuse me, are contributing to a sense of anxiety. So I think that certainly COVID-19, the restrictions, whilst was necessary and required, are impacting on people's mental health and maybe making it harder for some people to use the day-to-day mechanisms that they would use to manage their own mental health and support their own mental health. Those are disrupted, and so it makes it difficult to I suppose, be resilient in the face of the challenges that we're all facing at this time.
Thank you.
Thank you, and
I'd like to welcome both groups and thank you for your presentation. What strikes me, and this is probably an issue to be raised later with the HSE, is given the fact that COVID is having such a major impact on young people right across the board and from a very young age, you have to ask who is actually providing supports for people under 12. And as I say, I'll pursue that with the HSE. But in relation to that age cohort, in the teenagers in particular and young 20s, there's no doubt that the crisis has had a huge impact on those young people, you know, raising all kinds of questions about their future, restricting them in terms of meeting with friends, all of that kind of thing, and all of the uncertainty and fear that we all have. I just wonder, given the fact that pre-COVID we had long waiting lists for all mental health services for young people, and you have to wonder how we're going to cope as we come out of this. Has consideration been given to providing schools programmes as a way of reaching a wider cohort of young people? Schools programmes and also college programmes, and that's a question for Dr. Murphy.
I'll take that question. Thank you, Deputy, for that. Yes, there's been significant work that we've been doing in Jigsaw in terms of supporting schools, particularly supporting the post-primary schools. We've done that under the auspices of One Good School, so it's looking to support the whole school as an entity in itself. So we provide, I suppose, training for young people in terms of peer education and support for classes. We provide training for teachers, and we also provide training for parents. What we've noticed significantly during the COVID period is that we have a number of e-learning courses online, and we've had 7,500 courses downloaded in that time in the last 3 months, and nearly 5,000 of those courses have been completed by teachers. So it really is a significant, I suppose, need to get the support for teachers in terms of schools and being able to support young people. What we're looking to do to support schools as we move back into, and as they are moving back in September, is looking at the transition back into school, looking at managing anxiety, reconnecting with the classroom, minding your mental health, I suppose, self-care for teachers. And one of the things that we were very conscious of in Jigsaw and working closely with the HSE on is a broad psychosocial model, and it's looking at the view that mental health supports are not just provided on an individual basis, they're provided on a community basis, they're provided on a society basis. And I think the supports that we can provide for schools will be really important in terms of, as we continue on to see the impact on young people. We know that some young people will be anxious going back to school, some young people will be delighted for the experience of something new, and a lot of young people will be in the middle, and they'll be concerned in terms of their exams, they'll be concerned in terms of what does it mean for their planned and projected future. And I think what's really important is about normalising that experience and providing as much support as possible. But I think that there's a lot of positive work that's been done linking with NEPS, linking with the Department of Education and the Health and Wellbeing section of the HSE, that we're working together on this. But there is obviously a huge amount more to be done. I think the new sharing the vision and also the wellbeing guidelines from...
Sure, yeah. Could I just ask though, is it the intention to deliver a school-based programme? And has work been done on that?
Yes, that's the work that we're carrying out already.
There will be a programme provided in all schools. Okay, thank you.
Provided, well, yeah.
Just a question about your funding. How has that been impacted?
We have very good and steady funding from the HSE for the service delivery element of it. Our fundraising has been decreased for about 40%. It's been significant in terms of obviously community fundraising events. How
much does that amount to?
That amounts to about 700,000.
Right, okay. Okay, thank you. Just a question for Mr. Rogan then. What are you coming across in terms of substance misuse arising from mental health issues associated with COVID, particularly in relation to prescription drugs, alcohol and then other drugs?
I think it's a really important point in terms of, I think, one of the earlier questions mentioned the whole area of dual diagnosis. I suppose oftentimes when people are in difficulty and they don't recognise a range of different supports that are helpful and constructive in their lives, people are inclined to resort to old familiars, and particularly in the Irish context, alcohol is a huge issue. We've seen the CSO data on this. Even though pubs were closed, consumption of alcohol in the home, often at dangerous levels, has been a real feature here, and this is something we need to be very, very mindful of. But we're also seeing people, again, moving towards prescription drugs, and I think it was important earlier when we talked about the role of primary care. Primary care is really important here, but it's important that they have a whole range of tools and not just a prescription pad. We know, for example, at this stage, 10% of the Irish population are on antidepressants, and we need to...
Has that increased? I mean, I'm asking in the context of COVID, what are you finding, apart from the general kind of problems we have with it? But have those problems been exacerbated to a large extent?
I think they have been exacerbated. I suppose what we're...
on that at all?
an amplifying effect. So people are inclined to perhaps use and overuse their own traditional coping mechanisms. And I suppose every one of us has experienced this over the last number of months of being overwhelmed and having to take time out or space out, wherever it's just to try and reset our normal levels of equilibrium. But unfortunately, many people are inclined to use prescription drugs, street drugs, or indeed alcohol to excess to achieve that. We don't yet have a full measure on that, but the CSO data in relation to alcohol, which is probably best tracked, and I think certainly some of the recent drug seizures from the Gardaí have been very successful in, would suggest that there's an escalating demand there as well.
Thank you.
Thank you, Deputy Shortall.
Just to very quickly mention that while we have some very valuable data and research, it is limited in terms of what we know about the current impact of COVID-19 on mental health, and there has been some research carried out by Maynooth University and Trinity College Dublin in collaboration with universities in the UK. Mental Health Reform has carried out, consultations with its member organisations. But I think what is really essential is that we need a very firm and solid commitment from government to measure and monitor the impact of COVID-19 on mental health across the population, but also among particular groups of individuals, whether that's people from ethnic minority groups, people experiencing dual diagnosis, members of the homeless community, that really is essential if we are to really understand the impact and to plan accordingly.
Very much. Deputy Kenny.
Thank you, Chair. Thanks for each of the group's submissions. They were very, very insightful, and it's a very topical issue in relation to what's happened in the last 4 months in relation to the public health emergency. And I think we've had a juxtaposition in relation to the amazing outpouring of solidarity, support by, people coming together, which sometimes it wouldn't normally happen like that because of society. But that juxtaposition of that coming together, and also, the other position of self-isolation and the isolation of the public health emergency, and that has been has taken a huge toll on a lot of people, and that's almost unquantifiable. And the unintended consequences of that will probably be with us for a long time. And I think over the last 4 months we have seen in relation to public services that do not meet the needs and the demands of the populace, and that has shown the fault lines in the last 4 months. And when we talk about pent-up demand in relation to economical demand, I think there's going to be huge pent-up demand for mental health services, and that demand, can that be met with the particular resources that mental health services have at the moment? So that's one question. And the second question is in relation to the Mental Health Commission, in relation to their submission. Part of it, they say that 114 residencies, which are unregulated, so these are staffed community residency, can they give the definition of why they're unregulated? And because alarm bells kind of ring when you see unregulated, because if it's unregulated, who is regulating these services, particularly in this extremely challenging time for most people? So that's one question, and the other question is the kind of substantial question: can mental health service meet the demand that it's inevitable that's going to happen because of the public health emergency we're living in?
Deputy, if I can answer your first question in terms of can demand be met, I think it's going to be a struggle. It was a struggle before COVID. It'll continue to be a struggle now. I think what's already been mentioned and commented on this morning is the importance of further investment in mental health in terms of the overall health budget, and that would be hugely welcomed. I think it's really important in that we look at the mental health budget in terms of a system of care, and looking at the areas of prevention and early intervention where Jigsaw's focused on, and right up through longer term and tertiary care. And I think it's having appropriate targets and supports at each of the different levels. It's hugely important. I think Ireland as a nation have embraced the idea of prevention and the idea of early intervention around COVID-19, so people understand those concepts very, very well. I think it's hugely important then to promote the concept of early intervention around mental health, and as my colleagues have mentioned earlier on, the importance of mental health problems being identified and understood and arising due to COVID, but also getting the important supports for those as soon as possible. And I think the level of investment needs not just to be in the traditional mental health services and in the CAMS and the AMS teams, but looking at the wider supports and the broader psychosocial model of mental health.
It's particularly important that we recognise that the mental health services are a particular component of a service right across a whole population need. The profile of need is going to be quite different. If you take, for example, young people, a CAMS service is designed for 2% of the population, with a very extreme level of need. The question is what's before that? And I think similarly in the mental health space, in terms of we're increasingly seeing a movement towards promoting positive mental health, and indeed even a public health model even now begin to emerge with urban planning and how people live their lives and where they live their lives. So I think there's been many, many lessons here, and I think we have seen an extraordinary community bond and solidarity, but it also has shone a spotlight in terms of people sometimes we're most dependent on in terms of their terms and conditions, their employment, their precarious work. These need to be addressed, and we're at a reset moment, and before we repack the boot of the car, let's be sure we're putting things in there that we really want in our community, and these are huge decisions that we have an opportunity to reflect on and to revisit. In terms of the how we invest in our mental health services, it's really important when it comes to, for example, promoting positive mental health, that we do this in an evidence-based way. We've worked with, for example, NUIG in Galway with Professor Margaret Barry, who's a world expert in this area, and developed a new Level 9 programme with 25 graduates coming out just this year. So it means that we're much better informed in terms of what works, what's effective, what's acceptable to communities, and strategies and life approaches that people can take into their own lives to protect their own mental health and that of their family members and people in their community. You mentioned also in terms of unregulated residential settings. And again, this is something of not quite a legacy from our past, but you have to remember in 1950, Ireland held a world record for psychiatric hospitalisation. So almost 1% of the Irish population lived in what were then large mental hospitals. And as people moved back to their communities and were received well back to their communities, often with the support of volunteers and with staff members, large numbers of community houses were established. And sometimes these were quite congregated settings, sometimes not ideally or purpose built. Oftentimes convents, old nursing homes, small hotels were taken on for this function. So we still see the last embers of that. And unfortunately, as we've seen in the tragedy in the Marlborough Centre in Portlaoise, where 8 people who lived there passed away as a result of COVID, this has been a hugely traumatic effect for their families and indeed for the staff members who've made valiant efforts to protect that group. So just the physical infrastructure didn't lend itself to that. And it's really difficult for someone to live a dignified, independent life where they don't have their own accommodation, they don't have their own space, and where they're sharing, sometimes even sharing bedrooms with an unrelated adult. We can do better in 2020. We've made big progress, but we need to finish that task to make sure that everybody has good quality accommodation, can live in their own space and make their own decisions. And that whole message around recovery and stepping back into a full life within the community is absolutely critical to what we do across the mental health sector.
Mr. Rogan, and thank you, Deputy Kenny. Deputy Collins, you have up to 10 minutes. I understand Deputy Shannon has given you his time if you need it.
Thank you very much. Thank you, Chairperson and Chairman and the guests here today. It is estimated that mental health problems cost the Irish economy over 8.2 billion a year. During the past 4 months, face-to-face counselling has ceased for the thousands of adults and children who are supported by the mental health services in Ireland. Experts are warning that our social health care systems should be prepared for a tsunami of need, which will emerge in the aftermath of this crisis. Along with the many thousands of people currently attending mental health services, we are being told that there is a new at-risk group emerging from this unprecedented crisis. These include children, young people, adults and older people whose lives have been disrupted by economic and social upheaval. The distress suffered by this group may already be evident, while others will suffer from the delayed trauma. Given that our mental health services are already stretched to the limit and that there are extensive waiting lists exist due to a shortage of qualified clinicians, What do you know of plans are in place, if any, to deal with this emerging crisis in mental health service?
I think that point is really well made in terms of the, but it's really important where we put this resource. We need to front load it, and we need to be very, very careful too that for a whole population who've had this extraordinary, unique experience, a time of uncertainty, a space we've never been in before, and we've all been learning our way across this whole path as well, is that we need to front load, keep people well and in community, in their routines, in employment. And we know that unemployment is perhaps the most dangerous occupation to have. And in Ireland, we've seen this in very recent memory, and Irish people will remember just the corrosive effects of unemployment and recession has had, and the losses and the tragedy associated with that. So we know what not to do. So it's really important in terms of a whole series of measures across quality of life, people's health, and that people have access to services that are informal and easily accessible, and be that in the community and voluntary sector, in primary care, or indeed in mental health services, that these are properly resourced and are in a position to respond to people in a very constructive and creative way with a series of choices that are comfortable to the individual. And I think with sharing the vision, we've got a really strong outline there on how we can do this. And it's about outcomes. What is our objective? As a community, what is it we wish to see? So that everybody can live a full life and people can come in from the margins. We've seen people who've rejoined our country in recent years, coming back from overseas. We've had migrants joining us. We've had members of the travelling community, and we've had people living in precarious situations in homelessness. We can revisit these things because we know that these are damaging, but not just to our physical health, but also to our mental health. And it's unedifying for all of us if any of our fellow citizens live like this. So it's probably like the Americans used to say, nobody should be left behind. So we need to have systems in place in our educational establishments, in our workplaces, that are conducive and supportive to people's mental health, and recognising that people have been sometimes traumatised by this experience, have been seriously unsettled, and the uncertainty has had a corrosive effect. So we need to be patient, we need to be a bit kind, we need to be mindful of people's experiences. And family members have often struggled over the last number of months trying to do their day job by Zoom and homeschooling children at the same time. That has been extraordinarily stressful, and I think there's a recognition of that. And I think employers have been very good at stepping forward there. Most have been responsible in that space, but not all, unfortunately. So we just need to be alert to that piece as well. So I think across all of our community, we need to mobilise, be extra alert that we've all been through a tough time. And only by getting support from affirmation and acknowledgement from our colleagues around us and our neighbours, which has been a really, really powerful learning in all of this. I think you could almost consider COVID as something of a dress rehearsal when it comes to addressing some of the huge issues facing our society in terms of economically and unemployment, or indeed in climate change. So we've actually demonstrated what we can do when we pull together. And I think we can mobilise that attitude again for the coming months. We certainly could be unstoppable here.
Thank you. Could you, as we have site visions or inspections of mental health facilities continue during COVID-19?
I understand the Mental Health Commission is coming later in the day, and they're probably better positioned to respond to that question.
And would you have any idea how many cases of COVID-19 were detected in mental health facilities?
Again, the HSE are coming later today, and they have that data right up to speed.
Okay, during the lockdown period, many parents of both adult and young children who suffer from mental health issues found it incredibly difficult to manage their special needs children around the clock with no break or respite. Now that restrictions have been lifted to a large degree, how soon do you know will respite resume for these vulnerable people?
Again, I think perhaps the HSE might be in a better position to respond to that, but I think certainly a lot of families who get support from a variety of different providers, both the HSE and providers in the disability NGO sector, many of these services have had to be wound back or hours reduced, and even an element like transport to these services also has to be adapted in the context of social distancing and the provision of PPE. So there's going to be additional cost even in how these services are provided, and also time streaming to make sure that people who can't otherwise observe, may not fully understand the limitations, and find it very difficult in terms of sensory stimuli, etc., to engage with a person wearing a mask or perhaps even other forms of PPE. So I think there's still a lot more learning in this, and it's at the early stages of reopening on a highly prioritised basis, I understand it, but it's not a field I'm active in working in.
I might just go back to your first question, if I may. And In relation to resources, just to make a further point, I suppose there seems to be general acknowledgement of the need for further resourcing of mental health services, but I think we also need to get best value from the resources that are already in place. And I think that we spoke earlier about having multiple tiers of support and service available at a universal level, at a population health level, primary care, specialist services. I also think that what we need is better integration across those different levels of service provision, and better integration between the community and voluntary sector and statutory services. I think that in some communities and in some localities this works extremely well, but I think that it could be more consistent. And I think that the better the integration between services, the more likely it is that a person who presents to any point of the service system will be facilitated to get to the service that they need in a timely fashion. So I just think that's another important matter for us to bear in mind when we think about resourcing, just that we get the best use of existing resources in addition to the need for further resourcing.
Thank you. Just in the care of the elderly facilities, the HICU standards have recommended that 80% of bedrooms should be single occupancy. Do the same standards apply in mental health facilities across the country?
Well, I think one of the key issues there is it comes back to one of the earlier questions in terms of community residences. Mental health community residences aren't currently regulated, and my colleague Martin Rogan kind of explained a lot of the historical context to that, and I suppose the reason why that practice continues is because there is a flaw in our current mental health legislation that allows the unregulation of those residences. And mental health reform has been campaigning for quite a significant amount of time for the last couple of years for the urgent reform of Ireland's mental health legislation to ensure that the legislation is updated in full, so that people, if and when they go into a hospital for mental health care and treatment, that their rights are adequately protected. But reform of that legislation will also address that existing flaw and extend the powers of the Mental Health Commission so that they can actually regulate those community residences across our country. And as my colleague mentioned, there are concerns about the practices in some of those residences which have been well reported by the Mental Health Commission, which makes their regulation even more imperative.
Thank you. Thank you, Chairperson.
Next speaker is from Sinn Féin, Deputy Cullinane. Is it 5 or 10?
5 and 5, yeah, with Choctaw, Murraku. Mr. Regan, I just want to put a number of questions to you. I know that the Mental Health Commission obviously can speak for themselves, but the mental health reform and your organisation obviously has a role to play as well in advocating for improved mental health services. So can I ask you first, did you read the Commission's latest report that they published on the 2nd of July?
Yes.
And there was a press release that accompanied that report, Mr. Regan, and it read, "Too many residents are still being treated like second-class citizens." Would that be something that you would support? Would that be your experience of how some residents in acute settings are treated?
I think, unfortunately, in terms of the historic dimensions here, unfortunately, they are still acting in real time, and there's a real challenge for services to come forward into a more modern format. This is wholly inappropriate. People who can live in the community, their housing need predominantly is a responsibility of local authorities, and their health need for the HSE. That hasn't always transpired that way, and oftentimes the health service has continued to provide both home and care on into the future. So sometimes these people have been a hidden people, and sometimes their voice hasn't been heard. And again, in our organisation, we work with people with lived experience, some of whom live in residential settings, to make sure that people's needs are fully articulated to their preferred choices. And it's important that we don't speak on behalf of. In fact, all of our work is done in co-production, which means that programmes and projects and policies only go forward when people who use services and indeed family members are actively consulted on that, and that's where we take our lead.
Thank you, Mr. Regan. And you said in your opening statement, I know we took it as read, but in the submission, that you gave to this committee, that what we need is to ensure easy access to mental health services and supports across the continuum of care, from primary, community, acute and specialist services, as well as supporting individuals with existing mental health difficulties. So obviously, I would want to see that, and we support that. But we have to then base that upon what the Mental Health Commission themselves said in the report and their experience of going into some of these acute settings. And they go on to say, and the CEO of the organisation said, and I quote, that the fundamental human rights of residents are being overlooked. And they said that many mental health residents are still being admitted to outdated and unclean premises. That's not a very good start, is it, if we're looking to make sure that there is a continuum of care across all of the settings, including acute settings?
Yep, I completely concur. In terms of the quality of care for people at all stages in the mental health service, whether that's acute, community-based or in residential services, it has to be of the highest standard. If you can imagine in Vision for Change, for example, it had set out a programme where older mental health facilities would be sold and the proceeds reinvested. That accounted for, in 2006, almost €1 billion of new investment. Unfortunately, the recession that followed didn't make that possible. Now, there were lots of new resources put into acute inpatient residential settings. Inpatient settings for children were quadrupled in terms of numbers of beds, for example. But the residential programmes for people who often spent many years in institutional settings and have taken the step forward into the community.
But Mr. Regan, if we're not getting the basics right, there's something fundamentally wrong. If the premises are not suitable, there's something fundamentally wrong. When the Mental Health Commission says that no meaningful care plan for some patients, and that was in the case in 31 centres across the state, no meaningful care plan for patients, you would imagine one of the very first things, one of the very basic things that should be in place is a care plan for the individual. And if that's absent, then we're not even getting the basics right. Would that be a fair statement?
Absolutely. An individual care plan, there is little point in being admitted to hospital unless it's a purposeful event. And the question is, what is this admission about? What is the care plan? What's the person's contribution? What's the staff contribution to that? And this is a statutory requirement. So all service users in acute settings must have a care plan, and people in the community need to have a purposeful pathway as to how they're going to regain their independence and recovery and be authors of their own care plan in collaboration with healthcare staff. Where that's not happening, that is a serious failing on behalf of services.
And if I can give an example of a unit in my own constituency in Waterford, the mental health unit in University Hospital Waterford, there was a number of reports into that unit. One of them found that it was not clean, overflowing bins in some toilets, stains in the toilets, patients reported sleeping on the floor in the unit. The Mental Health Commission's report, if its overall report, went on to say that this year's report once again demonstrates that the needs and wants of mental health service users are not being prioritised. So I would wish it was better. But when the Commission itself is reporting that patients are being treated like second-class citizens, their rights, human rights are being violated, there's no individual plan for many of the patients in centres, and then even in some of the centres, patients with psychiatric needs, with acute mental health difficulty sleeping on the floor, doesn't paint a very rosy picture at all of mental health services, does it not?
Well, I think, as I say, these are found on inspection, so they're taken as read. So, and these are public facilities that are open to the public to see these. And we're not talking about second-class citizens. We're talking about Irish citizens who have needs, have a vulnerability, and often have issues in terms of their sense of personal dignity. And to go into a setting that's not clean, that's not adequately maintained, is simply not good enough. And the Mental Health Commission not only inspects but licenses approved centres as well, and has a responsibility to make sure that these standards are adhered to and held to the highest level. Also, the unit in Waterford, for example, every unit has a licence for a number of beds, and it cannot go beyond that number. And it's a question of mobilising additional resources, either in the private sector or in surrounding services, where there's additional pressures in that. These are, as I say, fundamental pieces, and it's extraordinarily difficult to promote person's dignity and independence in a setting that's not up to standard.
Thank you, Mr. Regan, and can I wish you well in your ongoing work in advocating for mental health patients and good mental health. Thank you.
Thank you, Deputy Cullinan. Deputy Burke, you have up to 10 minutes.
Thank you very much, and thank you to all of the to give us their views and their advice on the, I suppose, very challenging times that we've had over the last 3 to 4 months. Could I just touch on the issue in relation to young people? And one of the problems that I'm coming across is where young people who have challenges, either depression or mental health problems, and are distancing themselves from their parents, and their parents find it very frustrating because these are people who are over 18, but the parents find that they want to give support but find they're being excluded. And I'm just wondering, is there a need to provide support for parents in that kind of a situation? And it is, and the number of cases that I've come across in the last number of months is quite high, and it's a really challenging time for parents in trying to deal with it.
Yeah, certainly, Deputy. I think that often parents are the people who are most concerned about their children, the young people in their life, and that doesn't cease at age 18. And I think it can be particularly difficult for parents where their adult children, maybe at young adult stage, are experiencing difficulties and they're seeking to support them. I think that we have to certainly provide support to those parents. And one of the measures that Jigsaw took during the Covid-19 restrictions was to introduce a free phone service, which was principally used by parents, interestingly. Young people contacted us in other ways, but the free phone service was principally used by parents getting advice, getting guidance, getting information. Their children who they were concerned about, and sometimes these were adult children. I think that the balance is that we need to, I suppose, respect the autonomy and independence of young people who are over 18 and provide avenues for them to access support themselves, which is suitable for them. And I suppose to that end, Jigsaw has tried to introduce kind of low threshold entry points into a kind of service support, such as live web text, such as email contact, which might make it easier for those over 18 who aren't being necessarily facilitated by a parent to come to a service. But they themselves can take that initial step. They don't need to have a referral from another professional. They can choose themselves to access a service, to explore it, to see if it might meet their needs, and for us to be cognizant that that the needs of an 18 to 25-year-old might be slightly different to that of the general adult population, and they, to meet their needs.
But you think it's something that we should do more work on? Because certainly the case I found, the parents found themselves totally locked out, couldn't get any information, wanted to try and give supports, but found that it was just they were hitting a blank wall in trying to give those supports. And I'm just wondering, should we have some more constructive mechanism in place to assist in that case, in that situation?
I think the good mental health services always try to engage with the system around a person. And don't seek to, I suppose, individualise the difficulties or the support. So I think for any service working with young people, they will try to engage with parents, with friends, with a support system around the young person. Now, if a young person is over 18 and they decide that they don't want that, I think that's a difficult.
Yeah, okay. Can I just move on to the mental health reform report there? And in paragraph 2, subparagraph 5, it refers to many of the participants in the survey advised that they would not use, that they were no longer accessing treatment, were less likely to seek help from a GP, community mental health service, charity and voluntary organisation. And in doing that survey, were people asked for the reasons as to why they would not engage with any of the services again?
Thank you for that question, Deputy. Unfortunately, it didn't go into detail as to the reasons for why they wouldn't engage. But I think what's very important is that that finding really does indicate pent-up demand for our mental health services in Ireland, and you can see from that report that the findings are quite high, that it was about 40% who indicated that they wouldn't utilise community mental health services even if needed, and about 70%, which is huge, indicated that they wouldn't use emergency departments if needed for a mental health need. So it really does indicate that pent-up demand for our mental health services, and really demonstrates the need for our services to be ready for a surge or increased demand. And again, across the continuum, you know, when we're talking about mental health services and supports, we're not just talking about acute or specialist services, we're talking about continuum of support from mental health promotion right through.
When you're talking about that increased demand, how are you going to deliver on that demand if you have people who've already engaged with the service now you find that they do not want to engage with the same services that they did previously? How do you now deal with that issue?
Well, I think we really need to learn from lessons learned during, you know, the COVID-19 crisis in terms of how to engage with people during this time, how to ensure that they are adequately protected during this crisis, that there aren't fears around if they engage with a service that they will contract COVID-19, that the adequate protections are in place, including PPE equipment, that a blended approach and scaling up of different options of supports, including e-mental health infrastructure, so that people can access supports from their own home is provided. They're all the lessons that we need to draw on from this time, if and when we experience a second.
And can I go back to the issue in relation to GPs, where we were saying earlier this morning about 90% support is provided by GPs. Is there not a pressure point from with GPs in that one of the things in dealing with mental health is about giving time to the individual, and one of the problems that we have is that GPs are so under pressure themselves because of the volume of work they're doing. What additional supports do you feel we should now be providing to GPs so that they can come on board and give that time to the person who requires it?
Yeah, I can start with that, and I think you make a really important point that, as we know, primary care can meet a substantial demand of mental health need, but it has to be adequately resourced. And I think the first thing to mention is that, you know, GPs are one professional, but there's a whole cohort of primary care professionals that can be utilised and adequately resourced so that they can provide mental health support. So I mentioned earlier in the discussions that we know primary care psychology, for example, is usually under-resourced and there are significant waiting lists. So that's one very practical way of enhancing capacity at the primary care level, and ensuring that there's a range of talking therapies at primary care level for both children and adults. But there are other primary care professionals as well, OT, social workers, that can provide support. There are very good... I feel
that there's enough joined up approach on this, that here's the GP, they're running their practice. Yes, they know that there are supports there, but those supports are difficult enough to follow through on from a GP's point of view. Do you think there should be more coordination between GPs and the backup support services?
I think it's really critical that we understand the role of primary care here, and I think as the Deputy has pointed out very well, GP practice can be a very busy place, even at the best of times without COVID. And you know, it's been sometimes recommended or suggested that a GP visit can be 7 minutes, and that's 2 minutes meeting, greeting, seating, 2 minutes form a diagnosis, 2 minutes prescribe a treatment, and a minute to ask the person to move forward. And I think with the implementation of Sláinte care and better access, universal access to primary care, that time constraint should be somewhat reduced. And I must say, GPs have been very, very creative and very responsive, and they have a really important viewpoint, because they're not just seeing the person at one moment in time. They're seeing the person in the context of their family, they know the individual over a period of time, and they're recognising things are different. And we know that on average about 3 GP visits by either the individual or the family member can elapse before the difficult topic of saying, doctor, I'm really concerned about my mood or my level of anxiety or my drinking patterns, etc. So work with the Irish College of General Practitioners, Mental Health Ireland, we've worked with Professor Tom O'Dowd as well, in terms of understanding the tools and skills for GPs. And they play a really, really important role in early recognition and sometimes watchful waiting, but also that they have an array of options. And as Kate has mentioned, access to psychology, the counselling and primary care service, a whole range of different initiatives, not just a prescription pad. And we're also seeing that for people sometimes are reluctant to avail of mental health services. And sometimes that's out of historical stigma, sometimes that is out of hopelessness, sometimes it's a fear of losing control, that the service will somehow take over their lives. So we need to understand these much more. And increasingly we're seeing people availing of peer-led services, recovery colleges, where people can equip themselves with new understandings of mental health and self-manage their own care in a much more effective way. And I think people who've used the service often bring a unique insight that as professionals we don't have in our training. And they also carry a great sense of hope. That you're saying, listen, this is difficult. I'm not saying your story is going to be the same as my story, but these were helpful things in my life and these were things that were unhelpful. They are really powerful messages for a person who's feeling deflated or frightened about the future or feeling alienated or disconnected. So it's about having an array of options that are acceptable to the person themselves. So when we're supporting a person in terms of their mental health or indeed promoting positive mental health, we approach this on 3 levels. It's about strengthening the individual, strengthening the community, and reducing barriers. And we know that COVID has become an additional barrier that we need to navigate through and find creative ways to address. And I think we've seen some really strong examples of that over the last number of months, where services that routinely go the extra mile have now actually gone the extra kilometre. And it's not just frontline services, it's also support teams and managers working in the system have had to move heaven and earth to ensure that people get access to good quality services in a timely way. Because waiting lists are not really helpful when a person's in acute distress or perhaps considering self-harm. You need to address that right now.
Thank you, Mr.
Okay, thank you.
Front line of that in many instances.
Deputy Burke, if you want to come back in, there probably will be some time at the end. Deputy Burke, you've 5 minutes.
Okay, well, I suppose it would be fair to say, based on what everyone said here, we're starting in the wrong place as regards mental health services and funding. I think a number of people have stated, look, we're on 7% of health spending versus the 12% minimum that the WHO states. I'd like to commend the witnesses that have come in for their work, for their advocacy and service provision. Like, obviously web-based services are limited by geography, internet access and access to privacy, so face-to-face is often necessary. And I think we all fear that people who have suffered from adverse childhood experiences and older people who would also find themselves in bad situations will have experienced far worse, having been trapped without school, work or other services that allow for escape. So they will long-term require more services. The first question I'd like to ask relates to dual diagnosis, addictions, particularly drugs and alcohol, and the crossover with mental health. But an awful lot of times these people, they fall between services. And like that happens at the best of times. It's obviously possibly worse at the minute. They become a disaster for themselves, their family, and also to state services, particularly the Gardaí. I want to know what your views are as regards the protocols, resources and possibly legislation that's required to ensure that no wrong door to access of services is put in operation.
I think sometimes the kind of artificial separation between mental health and addiction services doesn't serve the individual well. And we need to build services that are person-centric and not funding-dependent or structural factors in terms of who's funding this programme. It's about how do we respond to the person in the complexity of their lives at that moment. And we know that oftentimes people do resort to alcohol, prescribed and indeed street drugs to respond to great distress they're feeling, and sometimes related to, as you mentioned, adverse childhood events, or ACEs as they're known as well, just that whole trauma-informed piece. And they can descend into a period of chaos for themselves and indeed for their family members who are reaching out and trying to support them and at the same time trying to limit the damage to this. So I think the no wrong door approach is a really important one, that people are received at point of presentation. and that the engagement continues on, what American colleagues refer to as a warm handover, so you don't leave a service until you've been successfully integrated into one that's more appropriate to your needs. And degrees of shared care. It seems bizarre to say to a young person with psychosis that if you just stop smoking the weed and then come back to us and we'll talk about schizophrenia and how we're going to treat that, that is not a realistic model, and it's not one that we're seeing. And there are opportunities too. We know, for example, in the prison population where people with addiction issues are well overrepresented, it does create an opportunity, a period of stillness and calmness to actually address a whole range of issues, both mental health and addiction issues. We're seeing, for example, in the Irish prison population, about 7% of the prison population, and all prisoners are assessed on arrival, have a psychosis. That's about twice the international norm. And about 80% of these people had availed of mental health service in the community, but sometimes fell out of service or declined service or were lost to service. So we need to understand these pathways and design services built around the individual as they are rather than we would wish them to be. And certainly the whole area of alcohol, and there's been quite a complex history in this, and I'm reluctant to criticise policy, but if we look at even the previous mental health policy, Vision for Change, the word alcohol appears about 3 times in the document. So it looks like a mental health policy for Saudi Arabia more than it does for Ireland. You know, we need to be much more honest and own these situations and respond accordingly. And GPs are often left with difficulty saying, where is the treatment portal for this person who's now ready to revisit their alcohol use? And does that happen in an acute hospital, in a specialist detox programme? At one point in the past, half of all psychiatric admissions related to alcohol. That's no longer the case since the late 1980s. The question is who has stepped into that void, and it's not always obvious who best does that.
Thank you. So straight protocols to ensure that this happens. Another group that falls between stools are people who are often told that's a behaviour rather than a mental illness, and these people can display behaviours which are dangerous to themselves and others, and sometimes it's only the Gardaí that can actually take action when a crime occurs, and it's a waste of services and puts people in real harm, and what needs to be done and what can be done.
Just to speak to that, I think a couple of the issues that you're raising, Deputy, speak to the situation that some people find themselves in, whereby the nature of their difficulties seems to exclude them from all services for some particular reason, and so they end up perhaps being referrals going between services without any clear line of responsibility and any clear service taking on to offer support to that person. And I think I spoke about service integration earlier on, and I think that this is often the key in these situations. I think that mental health services and services generally are often presented with very unique and complex situations which require some making sense of and understanding. And I think that if services can do this in a collaborative way and they can come together to discuss these things, they can decide on which service or combination of services is the best fit for that individual and for the difficulties that they're experiencing. So greater communication and greater collaborative decision making allows for, I think, nobody to have no service and to be bounced in terms of referrals, as some people experience. And it also allows, as Martin Rogan said earlier, for shared care, whereby different services come together to offer a suite of supports that might meet different needs within a person's life or a family.
Thanks very much, Deputy Murku. I suppose I'll ask a couple of questions and then bring you both in. Is that okay? No, thanks. I'm just wondering, obviously, you know, there have been various concentrations of COVID-19 in the population. One of them was direct provision. Others were meat plants, where there's a very high proportion of third country, of non-Irish workers and of third country nationals who are not from the EU. Where would such persons in direct provision or in migrant workers, and I suppose in particular undocumented migrants, where can they seek mental health support, or how do they seek mental health support in Ireland?
I think the model of mental health care in Ireland is based on a catchment area or sectorised basis. So a person should first present to their GP, and the GP will guide them towards services. And certainly in Mental Health Ireland, we've worked with migrant communities in a variety of different settings, and sometimes people are coming in difficult circumstances and also with a traumatic history, sometimes coming from conflict situations or histories of abuse or being human trafficking in really, really difficult circumstances there. But where you live largely determines which mental health service will engage with you and how that progresses. That has its limitations, and particularly for people who have an unstable address or even homeless persons, they can find themselves shuttling from place to place. And it again comes back to that earlier point made about point of presentation. The service needs to embrace the individual, stabilise their situation, and then see, well, where are the forward pathways for this person to move forward. But I think, like I say, the outbreaks we've seen in meat plants, sometimes that's about close proximity working, but it's also about people living in very limited, poor housing conditions, feeling unsupported, sometimes language issues in terms of not knowing what services are fully available to them. And these are the elemental questions about equity, about respecting people's work, about minimum wages. These have to be addressed. It is simply not possible if we know that the living wage is about €2 south of the minimum wage, or sorry, north of that. It means that the staff member is actually contributing €2 to their employer and to the state for their labour, and that does not respond to human dignity and does not promote positive mental health. So we need to revisit these, and these are difficult topics for all of us. When we go to the supermarket, we want cheap cuts of meat, and the question is, who's contributing to the cost of that? So I think we need to be honest and respectful and take a human rights approach and take a human dignity approach, saying, is this person at all stages of that product's life cycle being fully respected and fully rewarded for their work and their skills? And I think we've certainly learned a lot from that in the last number of months. And there's an opportunity as an island where we pull together and work together, that we respect people who come to our country and make a huge contribution to our economy, but that they're properly respected for that, and that promotes their mental health. But if they run into difficulties, their local GP, some services have an occupational health model incorporated, and the local mental health service will engage with the person as well. But there can be linguistic issues, cultural issues, and the HSE, I know, has invested in providing interpretation services, etc. But again, it's not ideal for a person to avail of a mental health service through a different language, and that can be a challenge.
Thanks. Obviously, there was a high proportion of cases among healthcare workers. There were some startling revelations here at the committee which were subsequently disputed, but they represent the unions that primarily represent healthcare workers will be coming back in. But in Canada, I noticed from a WHO report that 47% of healthcare workers reported a need for psychological support. In the People's Republic of China, healthcare workers reported high rates of depression at 50%, 45% reported anxiety, and 34% reported insomnia. Have you seen a prevalence of healthcare workers seeking mental health supports over the past?
We've certainly seen this, and certainly some collaboration with international colleagues, with Josh Morgenstein and Brian Flynn, who are experts in this field in the US, for example, and they were describing when they respond to a huge event that's traumatic, and that can be a terrorist event, a school shooting, a major weather event, it's time-bound. They know that this is really difficult. Time becomes elastic in the middle of this, but in 3 or 4 days, sometimes quite literally, the dust will have settled and people can come back to their lives again. So, and it can be really difficult in that 3 or 4 day period, but it has a terminus, it comes to an end. One of the challenges with COVID is we don't know, are we midway through this? Are we 10% of the way in? Where are we on the time bar that is COVID? And that makes it particularly difficult. And for healthcare staff, they have the added concern is that they're working very intimately with people with PPE and using all of the protocols and all of their professional skill sets. But they always have the concern, what if I bring this home to my family? What if I undermine our own household health, or if I'm supporting vulnerable people? And I know HSE has introduced models where staff have been able to stay at hotels, etc., so as not to do that. But there's another phenomenon we need to be alert to as well, and this is again described on that recent telecall with international colleagues, is a phenomenon known as moral injury. And moral injury is when a person in a leadership role takes a decision based on the information they have at that moment, and that's the absolutely correct decision. However, 2 days later, new information comes into the frame and it takes a different complexion. And for people who people look to in terms of their expertise, their wisdom, their experience in the space, that can have a really corrosive effect in terms of their ability to lead and their ability to make decisions into the future. And we need to be very mindful of that. So people have been exposed to difficult and graphic circumstances, fast-moving and overwhelming situations. Working in closed spaces with PPE is really difficult over long shifts. And I think the provision of employee assistance.
I suppose the specific question would be, have you seen a specific increase in healthcare workers seeking mental health supports, and could you quantify that in terms of a statistic as a percentage? I appreciate that, I'm trying to reduce this to sums, but
I think at this stage, having the data, as Kate has mentioned earlier, it's still too early to have that. I think a really important task for us all is to monitor this and understand it so we can learn from it into the future.
Thank you. Could I bring in Jigsaw on this, perhaps, and also on the issue of collaboration and interaction with associations like the FAI, GA and IRFU?
I think one of the things that I suppose is hugely relevant or important in this is that, as we've talked about before, is the importance of seeing from our perspective and indeed a community's perspective as the young person at the centre of the community, and the supports that they get at the moment and they have been getting in terms of sports organisations and community organisations are about trying to nurture and support those. We've continued during COVID to look to support those online as much as possible, and we've had some opportunities in terms of doing that. But I think it's really important in terms of, as we, I suppose, continue to see some restrictions relaxed, is that those organisations are coming on board and continuing to be able to support young people in terms of being able to interact more with the community. What we've also, I suppose, understood is really the importance of those organisations, but also the contribution that young people are making themselves to them in terms of leading and supporting them.
Okay, thank you. I wonder, I have two specific questions left. The first is, do either of you have concerns around prescription policies and reliance on pharma to treat mental health, or the prevalence of that in Ireland as a treatment policy?
I think in terms of the, particularly in primary care, it's important that the GP has a range of strategies to offer the individual, and pharma has a really important role to play in some instances. Where there's been a proper diagnosis, the person is very comfortable, and also that there's a number of other programs offered as well in terms of psychotherapeutic approaches, or even social prescribing, green prescribing, exercise programs, etc., which are really important. And also that we work with the individual not just as a solo, but in the context of their family or their chosen sports, be that friends and families as well. So in Ireland we have particularly high use of pharmaceuticals in the mental health space, and again sometimes this is in the absence of other options. But if you're availing of the wrong tool because it's the most available or the most useful one you have, that doesn't necessarily make it the correct one. So Mental Health Ireland doesn't have a viewpoint to particular types of medications or anything like that. We don't prescribe certain treatments or anything like that. That's a matter between the service user and the prescriber. But it is really important that there's a range of options and not just a prescription pad. Or that's
Mr. Rogan, thank you very much. I suppose my last question is, do you have a concern that the reporting and the way COVID is being reported is somehow contributing to mental health difficulties and the need for supports? I mean, we've had over 1,000 deaths, of whom I think 8 people have been under 65 without an underlying condition. Now, each of the 1,700 deaths is, of course, a tragedy. But we sort of maybe lose sight of the perspective that, during the same period of time in Ireland, we've had 3 times that number of deaths from cancer. Typically, you'll have 3,100 diagnoses of breast cancer in any given year, 2,680 diagnoses of bowel cancer, 1,161 diagnoses of gynecological cancer, and 3,300 diagnoses of prostate cancer. And all of those screening programs are in abeyance for now. That there seems to be this... if you were to listen to some media reporting now, one might think that the only thing that you might die of in Ireland right now is COVID-19, and I think we're just short of calling for lynchings at the airports. in terms of people who come to Ireland. I just wonder, do you think that that we need maybe a bit more perspective, and that there's that is contributing to distress and mental health problems for people?
I think we've seen in the last number of months, certainly people have been glued to their TV sets and consuming media, sometimes from responsible sources and sometimes less so, and social media in particular. I think in general the Irish media has been really responsible and has been a very important tool in communicating updates in terms of making sure that we're all in sync and in step with the various phases of reopening, and in terms of supporting individuals. And I've also been quite sensitive around just the human dynamics in terms of families and the interactions there as well. But I think we do need to be very mindful that some people perhaps spend their whole day on social media or on a screen of some description, and that can give a very distorted worldview. And like you say, these other conditions, they unfortunately are continuing in the background, and COVID is new, and also the fact that it's contagious means that it's a very immediate concern and risk. And people are also very mindful that they don't want to be a vector or an agent that will compromise a family member or a loved one as well. So I think generally it has been responsible. We've seen in other countries where there's been active denial, and that has been unfortunately replicated then in terms of the R number and the number of cases. So I think the media in Ireland generally has been responsible and has tried to give a balanced viewpoint. But like I say, there are many other conditions, including mental health issues, that seriously impact on people's lives, their quality of their lives, the duration of their lives, and in terms of even can be life limiting as well. So I think it is important that it's seen in context, but it has had a profound shifting effect for all of us in terms of our routines, our usual practices, and that is something that the media has a responsibility to carry, but do that in a respectful and a responsible way.
Okay, then I'd like to bring in Deputy Carol McNeill for 5 minutes, and then Deputy Burke for 5 minutes.
Can I just add on that there from a young person's perspective? I think a lot of the media and reports on the COVID have been through traditional platforms. They're newspapers, RTE, the news, and they're not where young people are at. Young people are more on social media and on their phones. And we recently did a Youth Talk event in collaboration with young people run by Jigsaw and the HSE. And a lot of young people were just voicing that they found that the COVID information wasn't accessible to them. So it was the language and the platform that it was being, I suppose that it was being updates, that young people feel that there isn't specific information for young people, or that it's not accessible and understandable for them. And maybe that causes a lot of anxiety. Young people aren't sure on guidelines sometimes, or they're not up to date with the stages and the phases. And they would like more accessible, youth-focused and youth-targeted resources and information so that they can be informed. Because a lot of times young people in care, for example, or with disabilities wouldn't have an adult or someone that they could ask these questions for. So that it comes down to them to understand, but it's hard to understand if it's not focused to them or not meeting them where they're at. If it's through the newspapers or on the news, that's not where young people are. So maybe if we focus on that and delivering the information to young people in a way that's accessible to them, that will definitely help anxiety and help young people manage and keep up to date and plan, which will help reduce some distress that they experience.
Very much, Ms McGregor, thank you. So I'd just like to bring in Deputy Carroll for 5 minutes, and I think we didn't start till about almost 5 past, so then Deputy Burke.
Thank you very much, Ms McGregor. That's a very interesting point, because of course we think that there's loads of stuff going out on social, but it may not be delivered in a way that's reaching people in where they're at. But I suppose we think that the volume of stuff on social is huge, but perhaps it's not the right tone, the right message, the right connection. So it's interesting. It's very interesting and important to get that feedback. Can I just go back to one of the things that we've discussed here with the Department of Education and with Parents' Council and with unions is the going back to school in September, and no matter what your stage is for young people, that there is an uncertainty there. as much because of the period out of school as lingering anxiety about COVID or the risk of transmission and so on. Can I just talk about your interactions with the department or others about the provision to meet the psychosocial needs of children going back to school themselves, anticipating increased anxiety, regressed behaviour or any other symptoms, engagement with provision of support for teachers who are often trying to meet those psychosocial needs in the classroom setting, whether any, I asked about the colleges of education, for example, providing seminars or web seminars on play therapy and additional types of therapy to help support teachers, support children as they come back, and also additional psychoeducation information for parents to be able to support their children through any disrupted period for them as they go back to school.
Thank you, Deputy. One of the things we've noticed, and I commented on it earlier on, is that we've had a significant increase in teachers accessing e-learning courses in Jigsaw, looking at mental health literacy, promoting mental health in school, but particularly around self-care for teachers. And what we've noticed is that has continued across the summer. And what we're working with schools, but we're particularly working with the educational support centres in Ireland, ESCE, is about developing webinars for teachers in terms of supporting them about that transition in terms of returning to school and supporting the pupils in the school, but also creating an environment where we have a conversation about returning to school is not just about focusing on exams, it's about focusing on the young person, the experience they've been through from early March and from before St Patrick's Day, not having that support from their peers, not having the support from teachers, and looking at that as a transition rather than thinking about how do we get back right into the curriculum. One of the things we have consultation with teachers and with schools about at the moment is about the timing of supports and how we manage that. Because obviously social distancing is a big issue. So we're looking at the moment to see how much supports we can continue to put online and support teachers. And that's something that really has been picked up. But I think, again, has been echoed earlier this morning, is about the collaboration and the networks, particularly between ESCE, between the department, between NEPS and between others, that there's a huge amount of work that's happening there. And it just needs to be coordinated more and to make sure that that schools don't feel overwhelmed, but also that they know where the right support is and where they can get valuable support.
Thank you very much. I think you're right. I think there is a lot of work going on in different places, and perhaps it's something that we ask the Minister for Children for, a sort of a standalone cross-government paper on the priorities for children as we reopen society, because there is a lot of work going on, but it has to be integrated. Can I just ask you just a factual question? Can you update me on the recommencement of assessments for children under the Disability Act? Do you know what the status of that work is at this point?
I'm sorry, I wouldn't have that information.
Okay. It might be for the next session. Does anyone else know? Mental health reform? No.
No, I don't have that information, but we can certainly try and get it.
No, don't worry. It's okay. I can pick it up in the next session. Thank you very much.
Thank you, Deputy Carroll. Deputy Burke.
There, in relation to the use of social media in young people, is there actually a planned programme to do something on this issue? And if it is, are all of the players involved in that, and I'm talking about from young people to the health service to the whole voluntary agencies, is there a coordinated plan to deal with that particular issue? Because I think it is a really, really important issue about getting that message out to young people and about the urgent need to have a very, planned programme in dealing with that.
I think, Deputy, there isn't as far as I know, a very clear, structured, national planned approach. But what there is good cooperation from, particularly within the youth sector and within the youth element of the mental health sector in terms of looking at that. But I think that we have a lot to learn from listening to young people themselves and what my colleague Royanne has.
But is it now maybe the time to look at this issue to see how can we improve and there's a lot of good work being done by people, and a lot of it is being done by people on a voluntary basis as well as having very good professionals involved. But do we need to be far more progressive on that, and maybe even look at other jurisdictions to see what has been done in other jurisdictions as well? But that now is the time to do that, rather than looking back at this again in 6 months' time or 12 months' time.
Absolutely. I think it's one of the real lessons in terms of learning from this. And I know in terms of our own experience in Jigsaw, we've really been influenced by the young people themselves in terms of how much they've embraced technology and they've used technology like TikTok and Instagram to provide really good, adequate and supportive messages for young people. So I think it's a really important time and a valuable time, and not a time to be wasted.
Okay, thank you.
Thanks very much. Right. Just one very quick, how did Jigsaw decide where your centres are located? I mean, obviously you're in the bigger cities, but in other areas outside of the bigger cities, how did centres come to be located in certain areas?
Historically, it's occurred in different ways. Initially, in the very beginning, about 16 years ago, it was about 14 years ago rather, it was consultations with local communities, particularly where there was high degrees of mental health concerns and particularly around suicide. And that's when we were funded from a more philanthropic base. We've worked closely with the Department of Health and particularly with the HSE in the last number of years about looking at the spread of services around the country and then looking at where we would best be able to use the resources. The difficulty is that we know there is a need for support in many different places. So now what we're looking at is a system of how we can expand and develop existing Jigsaw services. For example, Offaly has expanded into Laois, and what we were looking at is to see can we develop further services. But what we're actually looking at now, and particularly as a result of COVID, is the idea about national coverage would mean support both online and offline. And I think what we've moved into is providing the phone support and providing online support, which actually is able to provide greater levels of support for more people. The issue overall is about how do we get a balance between face-to-face and online support. So really it's about looking at resources. One of the bigger issues we have is that we don't have, we said 3 or 5 years of planned funding. We're always looking at it on a year-to-year basis. So I think certainly if we had that plan of structured funding, we would be able to work with communities and really support them to see where Jigsaw fits in within a system of care. And often at times in the past people have wanted us to develop a Jigsaw service, and we've been very careful and clear that we're providing a service at the prevention and the early intervention side to it. And the reality is that there does need to be a lot of other supports in communities for all of us to work successfully together.
Thank you very much. Thank you, Dr. Duffy, and thank you to all of our witnesses and speakers who came in to meet with us this morning. Thank you again. I'm now suspending the committee until 11:30, when we will meet with representatives from the Mental Health Commission and from the HSE. Thank you, colleagues.